Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Hematopoietic Stem Cell Transplantation for Advanced Systemic Mastocytosis by Selaletten Ustun et al. My name is Animesh Pardhanani, and I am consultant in hematology at the Mayo Clinic in Rochester, Minnesota, USA. My oncologic specialty is hematologic malignancies. Systemic mastocytosis is a hematopoietic malignancy that in adults is usually characterized by presence of the KIT D816V activating mutation. The four major disease subgroups include, number one, indolent systemic mastocytosis, wherein symptoms of mast cell degranulation, which range from mild to life-threatening, are the dominant issue. Number two, aggressive systemic mastocytosis, which is characterized by presence of organopathy due to mast cell infiltration of various organs, such as liver or gut. Number three, systemic mastocytosis with an associated hematologic malignancy, which is characterized by a concurrent neoplasm, such as acute myeloid leukemia, chronic myelomonocytic leukemia, or myelodysplastic syndrome. And four, mast cell leukemia, an aggressive entity that typically has a rapidly fatal outcome. The latter three subgroups, referred to as advanced systemic mastocytosis, are the focus of the manuscript under discussion. Conventional treatment of advanced systemic mastocytosis is currently suboptimal. Treatment with imatinib mesylate is generally ineffective in systemic mastocytosis patients who harbor the KIT D816V mutation. In aggressive systemic mastocytosis, mast cell debulking therapy in the form of interferon alpha or 2-chlorodeoxyadenosine is commonly employed. While both agents have the potential to improve organopathy, treatment responses are frequently only partial and adverse events are common. In systemic mastocytosis with an associated hematologic malignancy, treatment is primarily directed towards the non-mast cell disease component, for example, acute myeloid leukemia, since it determines the overall prognosis. There is no standard treatment for mast cell leukemia currently. The role of allogeneic hematopoietic stem cell transplantation in systemic mastocytosis therapy has remained unclear. Given the disease rarity, the allogeneic transplantation experience has been largely anecdotal, with published literature on this topic comprised largely of individual case reports. Further, most systemic mastocytosis patients having undergone allogeneic transplantation have had a concurrent aggressive myeloid malignancy, such as acute myeloid leukemia. Consequently, it is unclear as to whether patients with aggressive systemic mastocytosis or mast cell leukemia derive the same benefit from allogeneic transplantation. Barriers to successful allogeneic transplantation for systemic mastocytosis include, number one, the relative refractoriness of mast cells to chemotherapy, likely because these cells are quiescent. Number two, the relative resistance of extramedullary disease to graft versus leukemia effect, particularly given that extramedullary disease is highly prevalent in systemic mastocytosis. Number 3, controversy regarding existence of a selective graft versus mast cell effect after allogeneic transplantation, given the observation that neoplastic mast cells commonly persist after transplantation despite eradication of the concurrent myeloid neoplasm in patients with an associated hematologic malignancy. And number 4, controversy regarding the optimal pre-transplantation conditioning regimen. In one pilot study, use of a non-myeloablative conditioning regimen resulted in only short-term disease control. The accompanying paper by Ustun et al. Describes the largest combined experience of allogeneic transplantation in systemic mastocytosis. Investigators from over 33 institutions contributed information on 57 patients for this analysis. Not surprisingly, a majority of patients, namely 38, had systemic mastocytosis with an associated hematologic malignancy, including 20 patients with acute myeloid leukemia. A notable aspect of the study was exclusion of those cases where the mastocytosis component was discovered incidentally. The remaining cases had mast cell leukemia and aggressive systemic mastocytosis, with 12 and 7 patients in these subgroups, respectively. The anti-mast cell effect of allogeneic transplantation was most clearly evident in the 16 patients, or 28% overall, who achieved complete remission of the mastocytosis component, including 2 of 2 evaluable patients who achieved molecular remission defined as conversion to a KIT D816V mutation negative status. Other patients had lesser degrees of response, with 12 each achieving partial response or stable disease. Primary refractoriness was chiefly noted in mast cell leukemia patients. Consistent with prior reports, the associated myeloid malignancy, for example acute myeloid leukemia, was noted to be more treatment sensitive, with complete remission of this component being noted after transplantation in all 38 patients with an associated hematologic malignancy. Overall survival at 3 years was 55% for the overall cohort and 74% and 40% for the subgroups with an associated hematologic malignancy and aggressive systemic mastocytosis, respectively. For at least the subgroup with an associated hematologic malignancy, which had a reasonable number of at-risk patients during the follow-up period, a plateau was evident on the Kaplan-Meier survival analysis. The current study had shortcomings typical of a retrospective analysis. Further, the response criteria employed were improvised, given that detailed source data were not available for every patient. Additionally, compounded by lack of a centralized blinded review of bone marrow slides, which preclude an unbiased assessment of post-transplantation changes in mast cell burden. The time point for response assessment was largely limited to the day plus 100 follow-up visit after transplantation. Consequently, the time to best response, insofar as a selective anti-mast cell effect, remains unclear. Since there were no predetermined time points for evaluation after transplantation, the duration of response and progression-free survival data from this study remain difficult to interpret. Pre-transplant anti-mast cell cytoreductive therapy was not always administered, and when given was variable. Consequently, while pre-transplantation cytoreductive therapy and bone marrow mast cell burden were not significant as prognostic variables in the survival analysis for the overall cohort, it remains unclear whether certain disease subsets, such as aggressive systemic mastocytosis, would benefit from aggressive cytoreduction prior to transplantation, particularly given the survival advantage for myeloablative conditioning relative to reduced intensity conditioning noted in this study. Lastly, the lack of uniform study inclusion criteria render any comparison with historical controls treated with standard therapies difficult to interpret. Overall, the current study is important as a repository for the largest cumulative experience of allogeneic transplantation as a treatment for advanced systemic mastocytosis. It has value as a resource for physicians counseling patients with systemic mastocytosis in terms of outcomes following allogeneic transplantation. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.